Spine Institute. We're going to be doing a Deuk laser disc repair on a patient who has traveled here to have 2 herniated discs in her neck repaired with the Deuk laser disc repair. Deuk laser disc repair is essentially an endoscopic disc repair. It's done arthroscopically or endoscopically. And in the cervical spine, we go through the front of the neck. Now, I had a long conversation with this particular patient yesterday when I talked to her about the surgery, and I let her know that there's a chance we wouldn't be able to get this surgery done, just for the reason that she's had prior neck surgery done, and there could be a lot of scar tissue. So we're going to do our best, and hopefully we'll be able to get in and get it done. Now, we've prepped out both sides of the neck. She has what we call a shorter neck because you can see only down to about C4, C5. And we're doing 4, 5, 5, 6, correct?
Yes, sir.
We have our films up 2, 3, 4, 5, 5, 6. We got 2 herniated discs. We had kyphosis. It's better now. And her neck is supple. Shot. I need a pull on the arms. Shot. Wow. 4, 5, 5, 6. Huh? She definitely does not have a gag, which is good. Shot. Shot. All right. Yeah, you can relax a little bit. Is the what? I don't think the temp probe is a problem. No, the temp probe is fine. We have a temp probe in the esophagus. That's always helped in the past. I'm just thinking about our access. And what's her blood pressure right now? Good. Can we bring it up just a little bit for this part? Mm-hmm. Yeah, just so you know, you'll never be doing these. Yeah. Ever. Yeah, I wanna feel the carotid pulse. And it kills your fingers too. It kills your fingers. The amount of pressure that you have to put, it's very painful. But it's necessary in order to do it right. And we're totally relaxed, right? So when patients have had neck surgery before, they get a lot of scar tissue in the neck. And that scar tissue is going to make things potentially stick together that shouldn't stick together normally. It also creates a really kind of a thick membrane along the plane that you want to dissect and move. Let me know when you're at 100. And I'm starting to feel a pulse. Let's turn the suction off here, please. Still not as strong as I want it to be. So typically we go on the side opposite of the worst arm pain, and for this particular patient it's her left arm that bothers her the most. Many times people with a herniated disc in the neck, they're going to have, I wonder if we can extend her a little bit more. Is that possible, do you think? I mean, it's not terribly bad. It's actually better than her MRI picture, but if we can get just a little bit more extension, I might be able to. What do you think? How are we doing on blood pressure? All right. Also, this patient happens to have a bit of a thicker neck, so all these things work against us. She's got a shoulder roll, right? Yeah, I mean, I can tell, you can see the spine is pretty much almost lordotic, pretty much lordotic, where it used to be kyphotic in the MRI scan. 2, 3, 4, 5, 5, 6. So the X-ray view is pretty good with that. That's the arm pull X-ray, right? Huh? Yeah, yeah. No, I think that view is good on the lateral. I'm happy with that, and the AP shouldn't be a problem. I just want to make sure I can feel the carotid. Uh, Not consistently. Now I'm feeling it a little better, yeah. I'm feeling it better now. Alright, so let me go ahead and try again. You're totally relaxed, right? I want to make sure we're maximal. Yeah, why don't we just see do you have any EMG activity? Just go a little bit more, that's fine. Tell me how long until you're ready for me to try again. So when it comes to cervical Deuk laser disc repair, it's always anterior. It's a 4mm incision. The entire surgery is done through a 4mm tube. We call it a tubular retractor. And it's a transdiscal approach. We go through the disc to the back where the herniation is. And then I use a laser to remove the herniation with some grabbers to pull out pieces of herniation when they're big or stuck down. She's got pretty large herniations, but they're soft. You can see on the MRI there's gray on the T2 weighted images indicating there's water within the herniations, indicating that they're soft herniations. Shot. 2, 3, 4, 5. Huh? No, no. That's not the issue. Is muscle relaxer in? Shot. 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 Give me an AP. It's a quick AP. Alright. One more. Coker. Let's go lateral. Shot. Let's go AP. Yeah. A little too far off. Can you center that? Just a little bit. It's close. I don't mean that way, but well, go ahead and center the spine in the field and then rotationally with the spinous processes. Shot. All right, lateral. What do you think, Dr. Patel? It's pretty close, just a little bit off to the left, which I think is fine. Huh? Huh. Shot. Shot. One more time. Where's our blood pressure? So it's high. So, no, it's good. I'm glad it's high, just temporarily. Let me know where we are currently. That's it? But we hit it. Yeah, so if we were through the carotid, there'd be a hematoma. We're not getting any hematoma at all. So that's obviously one of the risks of the surgery. There's absolutely no blood clot forming. The neck is supple. There's no hematoma. There's really not even any bleeding. So I feel pretty comfortable that we are in the space we need to be, which is between the carotid artery and the esophagus. So we'll just wait another minute or two to verify that. And we are at the 2, 3, 4, 5 level. Yeah, you can I'm going to get a discogram anyway, so you can just wait. Let's see where we are on the blood pressure. So we spiked her up real briefly to 175 over 111, which is good for testing, but we're going to get her down after that. 150. Shot. All right, so we got a nice, one more time shot. We got a nice discogram. You can see the tear in the back, the dye leaking out in the epidural space. AP. Coker. Hold on. Let me get my hand out of the way. Shot. All right. So you expect to see us off to that left side because we're going for the left foramen. That looks, well, you had it pretty good. I guess it's fine. You can actually see the dye going out the left foramen. You see that? That black line going out where the nerve root is. That's where our herniation is that we're primarily concerned about. So yeah, the neck is still supple. I'm very happy. Let's go ahead and go back to a lateral. So I feel confident that we're in the right place through the right path, but we're going to find out 100% for sure right about now. All right, let's get those cables up. The best thing to do is to put them right here. Shot. I need a pull on the arms. Pull. Shot. That's pretty good. So 2, 3, 4, 5. Everybody agree we're at 4, 5? That's one of the discs we're fixing, right? Everybody in agreement? Shot. So I'm now pushing the guide wire out. So it's seated into the disc space. Shot. I'm going to take the spinal needle out. Supple. And now let's do a cycle another blood pressure. Yeah, I'll take the local. Louise, thank you. The light is giving me a shadow, but I could probably get around it here. Always bend this for me. Is there any epi in here? Two cc's injected. All right, so where are we at now on blood pressure? Cooking? Yeah, this is supple. I feel really good about it. There's no hematoma. Just let me know. All right, so good. Physiologic. And now we can bring it down to our nice range where we like it. Dr. Patel, will you pull the skin? Yep, perfect. Thank you. Of course, we hit a little, huh? I just injected local. Yeah. Right? What kind of look is that? Yeah. Take. So I'm going to bring a dilator down. And what we've done is nicked a blood vessel at the skin level. Shot. So our guide wire is in good position. We're going to have to bring it down. And I want to watch the tip of the guide wire. Shot. I need a decent pull. Shot. You want to make sure your guide wire doesn't advance into the spinal cord. That's bad. Shot. It's actually going really easily. I don't feel much resistance at all. I'm on the spine now. It's perfect. Shot. Yeah, I'm right on the ALL, anterior longitudinal ligament. There's no bleeding. We just had a little blood vessel under the skin that we nicked. That's about it. but no hematoma. The neck is supple. I'm happy. All right. So let's see how off to the left we are. Let's get an AP, Coker. For those of you wondering what's an AP, it's an anterior posterior. That means front back x-ray. So as you're doing this surgery, you have to navigate your instruments and tools by using an x-ray machine. Yeah. So I like to be within the realm of the spinous process width. Okay, come back to a lateral. And I'll probably aim a little bit more medial with my tip. I just wanted to see where the tip was, so I didn't want to superimpose the shaft on the tip. So we're just, basically, if you look at the front of the spine, there's two muscles that run on the left and right, the longus colli muscles. We're just at the border of the left longus colli muscle, the medial border, which is fine, as long as you're between the longus colli muscles. That way you don't get much bleeding. Now I like to try to push this through with my fingers. Shot. How are we doing there, Carl? So at this point, I've got it started in the annulus. Shot. I could probably take the guide wire out. Give me the mallet. Shot. Shot. Yeah, so shot. We want to put the dilator all the way down to where the herniation is. Let me have that, please. No. So the entire surgery shot will be done through a tubular retractor right here, 4 millimeters wide. This is the most minimally invasive surgery on the cervical disc in the world, and the most successful surgery for a cervical disc herniation, which is a herniation in your neck. There's really no other surgeon in the United States that does this technique, and really no other surgeons in the world except in Korea. There may be one or two. So if you want an anterior cervical endoscopic procedure done, until other surgeons learn it and become more competent at it, you're going to need to come to Deuk Spine Institute, where we do it here. Shot. All right, at this point I'm going to advance my tubular retractor over the dilator. Shot. You can see it going through the disc space. Shot. All the way to the back. Shot. Alrighty, that's pretty good. Take that. Shot. Perfect. So the tubular retractor is now right at where the herniation is, right at the back of the disc. So now we're going to go in with our scope and we're going to see this herniation. Don't be surprised, it's going to be blue color because we use a blue dye to stain the disc, and the degenerated disc will stain blue. I need my scope on. Any questions from our audience?
Not yet.
All right. For those of you who have joined us later, this is the Deuk laser disc repair. Cervical, which means the neck. And our patient has 2 herniated discs. We're going to try to get both of them today. The laser fiber is there. You can see it. Our focus is not good, but I'm about to fix that. Now, I need to bring the brightness down. It's overexposed. A little more. A little more. That's it. That's good. All right, and our laser should be on 20, correct?
It is.
And I need the pedal to my foot. So it's awfully fast. It's faster than it should be.
Okay.
So it should be 10 and 2.
It's 2.0 and 10 for 20 watts.
All right. Yeah, that's slower. All right, standby laser, standby scope. Let's grab some of this herniation out. So you're watching the Deuk laser disc repair, only performed at Deuk Spine Institute in Florida. Basically, anywhere else you go in the world for this patient's problem, they would do a fusion or an artificial disc. Both of them are, in my opinion, much worse than the endoscopic laser, because with this surgery, you're not getting any metal put in your neck. You're not getting your bones fused together. Laser should be back on already. Hello, sir. You got to be paying attention to what I'm doing, please, and make sure that you just get that laser back on when I go back in, okay? Thanks. So, stand by. There's a herniation right there. Now, people think herniations come out as one big piece, but about 95% of the time they don't. They come out in multiple fragments, multiple little pieces of herniation, not just one giant piece. And the reason that there's not one giant piece is for several reasons. Number one, their herniation could be staged in the sense that they could have herniated a piece and then it didn't herniate for a while and then it herniated again. Seems awfully slow now. Is it still at 2 and 10? All right, thank you. This is the back of the disc we're seeing right here, and there's the herniation.
We have a question.
Sure.
We have a viewer asking, is the needle in the surgery in through the front or the back of the neck?
Stand by. The needle goes in through the front. The disc herniations are in the front of the spine. The best way to get rid of a disc herniation is through the front, not through the back. Getting rid of a herniated disc through the back is next to impossible because your spinal cord is there and it's going to block the surgeon from gaining access to a herniated disc. All herniated discs except for foraminal herniation, which is still really not a good option going through the back of the neck. The only time we go through the back of the neck for this type of cervical disc herniation is when people have 4 disc herniations or 5 disc herniations. But when you have 1, 2, or 3, going through the front is 99.9% of the time always better than going through the back. I don't care what anyone tells you. I know these things for fact. I do all surgeries on the spine. In other words, there's not a surgery I can't do. I can do posterior, anterior, front, back, side, whatever. And I've done them all in my career. And I know what works. I know what's safe and what doesn't work. So yeah, if you have a herniated disc in your neck, the safest procedure and the best procedure will be through the front. If you have 2 herniated discs, the front. If you have 3, the front. And when I say the front, what I mean is the approach. The surgical approach should be through the front. So the surgeon should approach the herniation through the front, in my opinion. Now, is it substandard care to go through the back? No. The surgeon could go through the back, but in my experience, in my opinion, going through the front is going to be better. And I think most experienced spine surgeons would agree. Going through the front is always better in the neck. If you have more than 3 herniated discs, I think going through the front is too risky. There's too much chance of complication, problems with the esophagus, problems with the trachea, risk to nerves and other structures in the neck, blood vessels. So I recommend going through the back when you get to 4 herniations. So the Deuk laser disc repair is an endoscopic surgery done through the front. This is all disc right here that's part of the herniation. We're right at the base of the herniation. Basically at the part of the herniation that's still within the disc space, but sticking out. So this is like the bottom of the iceberg, so to speak. We're attacking it from the base, from underneath the water. And we have to go out here into the epidural space. But I'm not going to do that just yet because I need better visibility. I need to be able to see better. So I kind of peel this herniation away one layer at a time. By the way, right here, this is all a herniation here, the blue stuff. You have another question, Zach?
We do actually. We have a viewer asking, what would the recovery time for this surgery be if it was done on L2, L3, and L3, L4 in the back?
The recovery time is 1 hour for Deuk laser disc repair. It doesn't matter if it's your neck or your back. Literally, you recover for 1 hour and go home. It's an outpatient surgery. We've been doing this surgery now 13 years at Deuk Spine Institute. We've had 900 of these surgeries done, 900 in 900 patients. And thank God we've had 0 complications to date. But the recovery on average is 55 minutes. And people can go back to work the next day. You could do pretty much everything you want to do the next day. Even if you have a lumbar done, the only restrictions you're going to have are lifting and bending. Lifting and bending. So lifting restriction would be 25 pounds for the first 6 weeks. And bending would be no bending for the first 6 weeks at your waist. So if you're interested, submit your MRI or contact our office and we can give you more information. Deuk Spine Institute performs free video chats to anybody interested in talking about a problem with the spine. So we do a nice 10-minute free video conference with you over the internet. We don't charge for it. There's no obligation. And frankly, we have a lot of people who actually take advantage of that free consultation. We also do a free MRI review at Deuk Spine, where we'll review your MRI scan and try to figure out what you need done to help you out. All right, so what I'm going to try to do is get in a little bit further. She's still relaxed, right?
Oh, yes.
Good.
We have another question.
Yes.
We have a viewer asking, does the patient require a neck support brace post-surgery, and if so, for how long?
Yeah, so great question. One of our viewers says, do the patients that have this Deuk laser disc repair surgery require a neck brace? The answer is yes. All Deuk laser disc repair patients require a brace, whether it's a neck brace. There's another herniation, by the way. A neck brace or a back brace. So if you're having your lower back operated on, you need a back brace. If you're having your, don't hold this here. If you're having your neck operated on, you need a neck brace. There's another herniation, by the way. Do you see it come out of there? It literally came out from where the spinal cord is, and just we freed it up with the laser, and the pulsing of the laser pushed it out. So it's one of the nice things about this laser system is the ability to physically remove herniations with a pulse. So to answer the question, yes, you need a neck brace or a back brace if you're having the laser surgery done. Typically, patients will wear the brace for about 6 weeks. That's what we expect, 6 weeks. So I'm removing the herniation that's literally up against the spinal cord right now. And you can see I'm just taking my time. I'm taking it just kind of one layer of herniation at a time. So I'm looking over to her right side because she was complaining of right arm pain. She said last couple of days her right arm has started to bother her. Prior to that, it was always left arm. So I'm just checking out the right side. I'm sure there's herniation over there. You can actually see it on the MRI scan. So it doesn't surprise me that her right arm is starting to bother her. You know, herniated discs typically will cause symptoms that get worse over time. I don't know really any herniated discs that cause symptoms longer than a month that go away on their own. It can happen. It's just not common. It's pretty rare. Right, Dr. Patel?
Yes.
Yeah, I mean, if you have a herniated disc and you have symptoms from it, it's going to go away within the first few days, maybe by the first week or two. If it hasn't gone away, it's probably not going to go away on its own. You're going to need something done. So, my opinion, don't live with it. Get it fixed. They really, as they get worse and worse and worse, they cause a lot of problems for people. And I don't like seeing patients with problems like that that are fixable. That's kind of how our country has gotten into the opioid crisis. It's really from physicians treating patients with narcotic painkillers rather than sending them to get fixed. Now, granted, fixing neck pain and back pain was really hard to do just 10 years ago. We didn't really have a way to do it. But nowadays, we can do it pretty easily. Not every doctor knows how to do it, so don't expect all your doctors to be able to help you. You have to go somewhere where they have the most advanced techniques, because fixing neck and back pain or curing neck and back pain wasn't possible, really. The knowledge and the tools were not really available just 15 years ago. So that's why we have so many people with chronic pain. But the fact of the matter is, over the last 15, 20 years, with interventional pain management becoming more widespread and more interventionalists being trained, we're able to cure neck and back pain now with usually interventional procedures. Typically a facet joint rhizotomy is what's needed. But also, if a herniated disc is the cause, we can now fix herniated disc problems as well.
We have a question.
Yeah.
We have a viewer asking, how soon after getting this surgery would it be safe to fly back?
So if you had the surgery done, it's safe to fly the next day. Of course, if you have a complication during surgery, you wouldn't be able to fly back the next day. So we've not had a complication to date, but you never know. We could always have our first one. So you have to plan, I think, to at least stay maybe one extra day, I think would be the safest thing to do. So if your surgery was on a, say, Thursday, I would suggest flying back on Saturday. But if you really wanted to fly back, you could fly back on a Friday if your surgery was Thursday. So flying home the next day is certainly possible. People do it. We have patients who get this surgery in the morning and then they'll actually go to work that night, but we're not recommending that. How's our irrigation? Thank you. So we recommend, the next day, if you want to go to work the next day. If you have a light duty job that you can go back to. So there's a little bit of bleeding from the end plate. Not uncommon. I'm out in the foramen right now. And I'm just making sure there's nothing in the foramen. I think I see a little herniation there. So I want to go get it. But basically, this is really arthroscopic surgery. And arthroscopic surgery has been around for a long time. It started, I think, Dr. Patel, maybe knees? Yeah, there was the herniation that just came out. Y'all see that? Yeah. It started really with knee surgery, 40 years ago, something like that. And, of course, there's lots of surgery now that's done arthroscopically or endoscopically, laparoscopically, that wasn't done that way many years ago. So there's basically it's a technology that's finding more and more application. It's continuing to evolve in medicine and be used in more and more applications. This is the foramen, by the way, on her left at C4, C5. So you can see the uncinate process right there. And I feel like we've gotten the herniation out. There is a little bit of ligament there. All right. Let's see. Grab her. It's a little piece of herniation. So remember, herniated discs cause inflammation. That's how they cause pain. And whenever you have inflammation, you're going to have bleeding. So it's not uncommon to have some bleeding. It always looks worse on the pictures than it actually is. Remember, we're looking through a 4mm tube, so we're not really seeing a whole lot of bleeding here. I've already been in this area. I think there's just a little bit left. And typically we get a little bit of bleeding once we've completed the decompression, because the areas that are decompressed will sometimes ooze a little bit. All right. I feel like we've done pretty good. May want to take a little bit more of this out. By the way, the bleeding typically comes from also bone spurs. You can see we removed. How's her blood pressure, by the way? We may let's see where it is. Let's stand by on the laser. We have no irrigation, guys. Come on. No, you don't. Where's your fluid? Where's the fluid? Right, but where's the one that's connected to me, coming to me right now? All right. And it's full. That's better. But what was going on before that? It was closed. All right. That's okay. You know, the reason we want to figure out what we're doing wrong is so we can fix it for the next time. All right. It's better. It's better. Huh? Thanks. So, what's the problem, guys? No, the irrigation's good right now. But you can see how much better the view is when you have irrigation, right? That to me looks like a herniation. Yep, we're all the way out in the right foramen, by the way. I'm just peeling this herniation right off the nerve. You see that out there? Just about done. And even if you can't get all of it, which you shouldn't try to get all of it, because you're going to end up getting the nerve root. So you can see the fibers of the PLL. You want to get as much as you can safely. This is just scarred down herniation right here. You see the bone spurs there. Zach, any more questions from our audience?
Not yet.
All right, we're just about done with this level. I'm going to just go back and look at the left foramen. Another herniation there. Another piece of herniation, I should say. Those are the fibers of the PLL. Again, you're not going to get 100%, so don't expect it. There's no surgery in the world that gets 100% of the herniation. You want to get what's causing symptoms for the patient out.
We have a question.
Sure.
If you were asking, can bone spurs be removed with this procedure?
Yeah, bone spurs can be removed with this procedure. As a matter of fact, I removed a lot of them. That's what was bleeding earlier, just a few minutes ago. If you go back and look, on the edge of the end plate was all the bone spurs. But see this right here, right there, that area, those are bone spurs there. And they've been removed.
We have another question.
Yeah.
We have a viewer asking, what would be the contraindications, if any, for this surgery?
Contraindications would be surgically if you have a large osteophyte or bone spur in the front of the spine, then I can't get into the disc space. If you have basically like a fracture of the spine, we wouldn't do this surgery. If you have what's called OPLL, or ossification of the posterior longitudinal ligament, we wouldn't do this surgery. Basically, the indication for the surgery is a soft disc herniation with a bone spur, but just a small to medium-sized bone spurs. This is 99, probably 98% of people with disc problems in their neck. This is the surgery they're going to want to do. Really bad deformity would be another reason, like scoliosis that's really, really bad in the neck. These are bone spurs right here. Okay, so people wonder, well, I didn't know laser could take off bone spur. Well, lasers are used to cut steel, you know, in factories all around the world. So Lasers can easily cut through bone. Didn't you watch Star Wars? Just kidding. All right. We've gotten all the herniation out back here.
We have another question.
Sure.
We were asking, do you know why this surgery isn't available in other parts of the world, such as Europe, yet?
Do I know why this surgery is not available in other parts of the world, such as Europe? The reason is, there's a couple of reasons. Number one is that it's not being taught yet in residency. So surgeons learn what they learn in medical school, but probably 95% of what a surgeon learns is during what's called residency. Residency is where we go after medical school. So I did 7-year residency in neurosurgery. That's standard in the United States, 7 years. And nobody in my residency does this. And I went to one of the best residency programs in the world for neurosurgery. So fact of the matter is, if the residents aren't trained to do it, or you don't do a fellowship in it, you're not going to do it in your practice. That's number one. So there's a lack of training sites, which is kind of why we broadcast these surgeries, so I can teach other healthcare providers, like doctors, nurses, whatever, about this surgery and that it works. All right, I think that's it at this level. So number one, awareness. Number two, not taught in their residencies or fellowships where they go, so they're not going to do it in practice. And I had to go overseas, for example, to Korea and learn how to do it. And back then, the Koreans were doing them a lot. They were doing a lot of these procedures. I think from what I heard is they've stopped doing them because they've had some bad complications. That's a huge herniation right there. That just kind of snuck out around the tube. So I'm going to see if I can grab it out. So, number one, nobody really knows much about the surgery, so it's hard to get interested in something you don't know about. Number two, it's not being done in all the training centers. There's about 120 neurosurgical training centers in the United States, 120 universities, and 0 of them are teaching cervical endoscopic. Now, one of them is teaching lumbar now in New Mexico, but that's the only one, okay? And in other parts of the world, they don't even really know about the surgery. It's so new and so advanced, the people don't know about it. The doctors don't even know about it. Now, have I presented at meetings? Absolutely. I've been presenting this surgery and its results at neurosurgery meetings, like the American Association of Neurological Surgeons, the Congress of Neurological Surgeons. They've all accepted our abstracts. They've all, it's the dilator. They've all had me present. So the societies are doing what they can to make people aware of this type of surgery, but the surgeons are literally coming and they're amazed, but then they don't do anything about it. They're like, well, I already do enough stuff. I don't need to add this to my list. So the other reason I think is because a lot of people don't take pain seriously. Right, Dr. Patel? Surgeons don't take pain seriously. All my colleagues, neurosurgeon colleagues, they don't believe in fixing pain. They just believe in fixing aneurysms, AVMs. Most neurosurgeons won't tell you they can fix your pain. The only kind of pain they really focus on is like trigeminal neuralgia, or glossopharyngeal neuralgia, basically cranial nerve neuralgias. But why they don't try to cure back pain and neck pain, I don't know. It's weird. It's like, I don't know. All I can tell you is they don't. And then you got the issue of access to the equipment. Okay, take this. What do I mean by that? Well, all the tools you're seeing, all these little instruments and retractors and stuff is expensive, and it's really hard to come by. We spent probably $1.5 million here at Deuk Spine Institute buying all this equipment. It's not standard in every hospital. It's not found in any hospital unless you specifically buy it. So there's the cost of the equipment, which hospitals these days won't even pay $10,000 for a new piece of equipment. I mean, it's like a big production just to get a hospital to spend any money, let alone millions of dollars. So the cost of the equipment is one issue. And the last thing that I would say is this is probably one of the hardest spine surgeries you can do because of the access to the spine. I mean, obviously, once you get in and do it, it's not that hard, but it's extremely risky and complicated, and it takes tremendous technical ability and experience. So it's not something that can be picked up quickly and easily. It's the technique is very different than anything neurosurgeons or orthopedic spine surgeons do. So very difficult technique, has to be trained over a course of about a year. That's not being taught in residencies and fellowships anywhere. The equipment is very expensive and it requires a large capital investment, and maintenance costs are huge. We just bent one of the scopes, just barely anything, like a degree, and it's $5,000 to repair it over in Germany. So the cost of maintenance is very high as well. So basically it's cost prohibitive, and it's very skilled, technically skilled. It's not like doing a knee scope. If you look at knee arthroscopy, it literally took 20 years for knee arthroscopy to become mainstream. And that's scoping a knee. A knee you can't kill somebody with. You just stick a little thing in the knee and it's no big deal. You might get an infection, but that's about it. With this surgery, you could kill somebody if you don't do it right. So the risks are much higher with this type of surgery than with a knee scope. And it took 20 years for people to learn and accept knee arthroscopy. Imagine how long it's going to take for surgeons to try this, right? It'll be 100 years before this is mainstream. So there's your answer. Ready. Go ahead and take a shot. All right, 2, 3, 4, 5. Everybody in agreement? All right, Carl, are you ready on the shoulders? Watch this, Dr. Patel. We don't want to break this or bend it. So watch the end here. I kind of pulled the laser in. So let's take our time. We're going to hold on any questions for a few minutes while we reposition. All right, I'm going to need to see down lower a little bit better. Is that our best shot there, Carl, with the shoulder pull? I don't think so, right? So let's try it on a count of 3. Let's pull shoulders and give me a lateral. 1, 2, 3. That's our best. 2, 3. You need to come south with the fluoro. Yeah, we can do some inline traction on anesthesia part. I mean, the jaws are pretty lined up, but we can just pull this a little bit. And let's try again. 1, 2, 3. All right, it's pretty bad, but it's not horrendous. Huh? Yeah, I can see it. No, it's not going to help. Can you play with the collimator maybe and give us a little more oomph? Are you pulsing?
Yes.
No, don't pulse. This is not the time to pulse. So take it off pulse. Get the collimator set properly so we maximize the beam right out of a narrower window so we get more penetration. Let's try that. And then let's get ready to try again. So with surgery, really the big issue is preparation. As long as you prepare properly, you're going to have great results. On the count of 3. 1, 2, 3. All right. Well, we somehow managed to darken the shoulders even more. You see what I'm talking about there? I don't know what we can do to make that better. All right, I'm going to start moving on this one. 1, 2, 3. All right. And I'll need an AP in a minute. Shot. That's good, Dr. Patel. Give me an AP. Coker. Yeah, that's good. Take it whenever you're ready. That's it? All right, so we're in the midline, which is good. We don't need the Raytech. So go back to a lateral, please. The AP looks good. I like it. I just don't know if I can get down safely to the next disc, but let's see. I like the shoulder pull. Wait a second, though. Don't do it yet, Dr. Patel. Give me a second. Give me. I know. I can pull this side, but I'm waiting. All right, shot. All right, that looks much better. So relax for a second. Shot. What are we, halfway there? I'm on a big osteophyte, huh? Let's try. Shot. I need another AP. Stay where you are, Dr. Bill, just relax a little bit. I don't want the body moving too much. Ah, it slipped. Yeah. There we go. Wait a second. Shot. Feel like I'm on the disc space now. Lateral. Quick lateral. Stay where you are. Do not move. Nobody pull. Nobody move. I'll pull the shoulder a little bit with Dr. Patel. Let's see where we are. Hopefully we're over the disc space. Shot. Pretty much. So 2, 3, 4. That's 5, 6, right? Okay, I feel the disc space. No. Too aggressive, Dr. Patel. Too aggressive. Shot. All right, we're over the disc space. AP. Quick AP. Nobody move. Nobody move anything. Just give me a quick AP. Let me see if I'm in the midline. All right, off to the side. So pull it back. And shot. That looks good. Let's do a real AP. Take your time. Get it lined up. Watch your hands, Dr. Patel. You don't need to pull. All right. I don't know. Why is it so overexposed? Just do whatever you need to do. Get it less exposed. Shot. That's better. All right. We're in midline, which is good. Let's go lateral. Now I can feel the tip, and this is honestly, there's several parts of this surgery that are extremely, let's just say, require a lot of delicate precision. Shot. All right. And this is one of them. Take mallet. I'm going to seat this into the annulus. Shot. All right, good. Pipe cleaner. Get ready to pull. Shot. All right, it's pretty good. Clean the pipe. Shot. All right. And shot. All right, good. And now we need to do our discogram. So what's the point of this surgery? The point of this surgery is to get rid of the herniation and get rid of the cause of the herniation, which is the annular tear, the tear in the annulus. It's going to be a good one. Pull and shot. We just need to see a little bit more. All right, so let's do a little pull, Dr. Patel. Watch your hand. Watch your elbow. Is that it there? All right, so I think we need a little more dye. I mean, you could see the dye. He's fine. And shot. Wait, shot. All right, you can see the dye's leaked out into the epidural space, right, Dr. Patel? You see it, I see it. Yep, Coker. Zach, any questions from the audience?
We do have one. We have a viewer asking, I've been recommended for a spinal cord stimulator, but I've been told I have to go to physical therapy first. The last time I went to physical therapy, my problem got worse. So they're wondering, is physical therapy always mandatory before a spinal cord stimulator trial?
All right, so we have a great question from one of our viewers. He or she's been recommended for spinal cord stimulator, and they've been told to go to physiotherapy, but they feel worse when they go to physiotherapy. Very, very common complaint when your problem is a joint pain usually, and joint pain doesn't get better with physiotherapy. Usually, a lot of times, with the spine it doesn't. With disc problems especially. So, do you have to? That's really up to the doctor putting the spinal cord stimulator in to make that determination with you. I don't think we require it, but we do require a psychiatric evaluation, right? I mean, that's the insurance companies mandating it. So there's,
Physical therapy too, but
they do. So apparently the insurance companies a lot of times will require that the patient undergo like psych eval, certain medication management over a period of time, physiotherapy, maybe other type of injections. But so to answer your question, the requirement for physiotherapy may be driven by the insurance company, basically trying to avoid paying for your procedure. Pull, because if you don't do the physiotherapy, you don't do the psych eval, you don't do a lot of the requirements, and they don't have to pay for it. So it's a way of getting out of paying for your medical care if it's driven by the insurance company. Now, if the doctor feels it's necessary, then that's a discussion between you and the doctor, your doctor, okay? At Deuk Spine Institute, we do spinal cord stimulators, but we always reserve it for people who we don't have a fix for otherwise. Or if they're just medically not fit, they can't have a definitive surgery because they're too high risk for surgery. So I personally believe that there are too many spinal cord stimulators being put into people who don't need it, people who should be getting a fixed procedure, not a cover-up procedure. The stimulators are not, in my opinion, your best option. Your best option is to figure out what the source of the pain is and fix the source. There's only about 8 causes of back pain, and there's only like a couple of causes of neck pain, more than, maybe 6, 7 causes of neck pain. And it's all the causes of neck pain are fixable, so you don't really need a spinal cord stimulator. And the same goes for back pain. 98% of back pain causes can be fixed with usually a surgical procedure or an interventional pain management procedure and therapy, and you don't need to be putting a spinal cord stimulator in. The problem is that most doctors don't know how to fix back pain or neck pain, and therefore they just want to cover it up with a stimulator. So we always feel that fixing the problem is better than covering it up when it can be fixed. The problem is most doctors can't fix it, and most doctors can't diagnose the cause. So what ends up happening is they just call it chronic back pain, and they end up putting a stimulator in to cover it up. Does that make sense? So rather than having the knowledge and experience to solve the source of the pain and fix it with proper treatment, they just cover it up with a stimulator, and we're seeing more and more stimulators being put into people unnecessarily. So I would caution anyone thinking about getting a stimulator, first, even if it means doing a free evaluation or free consult at Deuk Spine Institute, we do a lot of free work for the community to try to help people, and we don't expect them to come here and get fixed. So you can have a free MRI review, you can have a free video conference, you can have a free office visit if you want. I mean, we do everything we can to help advise people properly on what they should do for their back or neck pain right before they do something stupid. And honestly, I don't blame the patients, I blame the doctors. I blame the doctors for the opioid crisis, I blame the doctors for the spinal cord stimulator crisis, which is going to be next. Honestly, doctors just need to go out and learn the causes of back and neck pain, and then refer their patients if they can't fix it themselves. Please be careful. This is $1,200 grabber. You know where to buy this if we break it, right? Just take it. Long story short, I truly believe people can get their back and neck pain fixed. I do it all the time. I've been doing it for 20 years. And a spinal cord stimulator, even though we put them in, it should be a last resort for people who really can't have a fix. So really good question about the physiotherapy. This is the base of the herniation. It's really fluffy and it's pretty scarred in from all the chronic inflammation. There's a piece. There's a herniation right there. Y'all see that? Just popped in. So what's happening is herniations occur. Are you okay there, Carl? Herniations occur because of what are called pressure differentials. All right? So when the pressure inside the disc exceeds the pressure outside the disc in the epidural space where the nerves are, and there's a path of least resistance, darn it, I need to grab it again, then you're going to get a herniation, right? You get a movement of fluid. So bulk fluid movement occurs usually because of pressure differentials. So when you lift something with your arms, it actually puts a lot of, there's a herniation right there. You see this, Zach? Can you use the eye in the sky? Let me see. You see this thing?
Yeah, we see it.
That's one of the herniation fragments. Anyway, when there's a pressure differential, like if you lift something with your arms, all the weight of what you're lifting goes to your spine because your arms are attached to your spine. So any weight in your arms goes to compressing the discs in the spine. So what happens is when you compress the disc then gets squeezed down, and the jelly in the center of the disc, called the nucleus pulposus, which is what we just showed you, it wants to get out of the disc. It pushes against the wall of the disc, called the annulus fibrosus. Well, when there's a hole in the annulus, that annulus allows the nucleus to squeeze out, and that's what we're seeing. We call that hole in the annulus the annular tear. Oh, there's another herniation right there. You see that? It just came from where the spinal cord is back into the disc, where our tube is. So again, what I'm doing is I'm giving the herniation a chance to come back into an area of lower pressure, right? So clearly the disc is pushing up against the spinal cord is pushing back against it. So now I just created a way for the disc herniation to escape the pressure of the spinal cord or the posterior longitudinal ligament, and it's come back into the disc space and it's come into my tube, and then I get to see it and grab it. So we call that a reverse herniation, and we coined that term, reverse herniation, at Deuk Spine Institute. I coined it, Dr. Deuk Majan, when I published our paper in 2012 on the Deuk laser disc repair. So I coined it because nobody else has ever really had that experience. It's something that you can only do when you go inside a disc herniation and attack it from the bottom and actually see it. There's a herniation here as well. This one is down there, is more scarred up.
We have a question.
Yes.
We have a viewer asking, can this type of issue also cause numbness of the feet? I'm post-RFA cervical 2 years ago. I have tingling and a little burning of the toes sometimes. Knee reflexes are hyper, and cervical MRI is pending. Yeah.
So great question. We have a viewer who says, could my cervical disc herniations be causing numbness in my feet? I think tingling in my feet. Brisk reflexes. Yes, the answer is yes, they can. It's not common though. And if somebody came to me and said, I've got numbness in my feet, the first thing I would think of is neuropathy. And I would want to get probably a nerve test on their feet and see if they have neuropathy. But certainly a cervical disc herniation can definitely cause balance problems, loss of control of their bladder or bowel. It can cause numbness or tingling in the feet too. So all those things are definitely possible. It's just not the first thing that I would think of as being the cause. I would go to neuropathy as number one. Number two would be a pinched nerve, either in your back or somewhere in your foot. And then, maybe a spinal cord problem in the thoracic area. And definitely cervical disc herniations with spinal cord compression can definitely cause it as well. So I think the cervical MRI is a good idea. But if I were you, I would take advantage of Deuk Spine Institute's free MRI review and do a video conference with me, Dr. Deuk Mage, and that can be set up through our website, talking to Lauren, and Lauren can arrange that for you. I would be happy to spend my time trying to advise you and get you going in the right direction to get fixed. So that kind of brings up another point, and I'm glad we're talking about it, which is something called medically unnecessary procedures. And a medically unnecessary procedure is a surgical procedure that you get done that wasn't the right procedure for your problem. And I'm going to tell you something. It happens all the time today, and it's been happening for years. I mean, literally, there are probably 1 million procedures done a year, in my opinion, just in pain management alone, that are inappropriate. I'll give you the biggest example. There's so many doctors that do epidural steroid injections for patients with facet pain. Facet is F-A-C-E-T. Facet pain is the most common cause of chronic back pain and chronic neck pain, and yet most doctors don't know how to do a facet joint injection or a facet block. So instead they do an epidural. And the epidural is not going to work to fix the problem. And we could tell that ahead of time. And so that becomes, in my opinion, an unnecessary procedure for that diagnosis of facet syndrome. And yet they're done all the time because the doctors, an epidural is a 5-minute procedure. It's quick, it's easy, and it pays $100 or so. So it's something that a lot of doctors will just do an epidural for people with back pain. The only kind of back pain that an epidural is going to help is discogenic back pain, meaning back pain that comes from a herniated disc. And that only represents about 10 to 15% of back pain. So chronic back pain. So basically, if surgeons are doing epidurals on every back pain patient, then they're probably going to be not helping 95% of them, because most of the time the patients are having facet syndrome, facet pain. Now, if the patient has leg symptoms that are due to an irritated or pinched nerve, then I think it's reasonable to do. And we do epidurals at Deuk Spine Institute all the time, but we do them on patients with leg symptoms, so radiculopathy, sciatica, things like that. Again, this patient's had chronic inflammation, so we can see that there's a fair amount of inflammatory bleeding going on, or bleeding related to the inflammation. Any way we can get more flow off that saline bag? Is it empty? Well, as long as your compression sleeve is over the liquid in the bag, you should be able to increase the pressure, right? Does that make sense? But if you're squeezing a part of the bag that doesn't have any liquid in it, you're not gonna be able to do anything. I just decided to go to the other side and start working on other area while that bleeding stops. All right. Let me have standby scope. Let me have the dilator. And let's get a fluoro mallet. I'm going to try to bring this tube down a little further. I need a shot. Just give me a shot. Let's see what we got. All right. I need to pull on the shoulder. And can we get the x-ray up top, please? Perfect. Shot. That's it right there. Shot. Are we pulling the arms? Can I have the impactor? Yeah. Ah. I'm going to need to pull the shoulders. Mallet, got it. Raytech, come on. Shoulder pull shot. All right. That's it's better, but it's still a little overexposed. But definitely more in line with what I want. Shot. So I'm trying to use the dilator to advance my tube a little bit more into the herniation. Let's pull the shoulder and shot. All right, good. Take that. Take. Good. Watch your hand.
We have a question.
Sure.
We have a viewer asking, I'm having an instrumented spinal fusion and laminectomy with decompression.
I need an endoscopic view up top, please. Go ahead, I'm listening.
How
I'm
long?
having a something spinal fusion.
Instrumented spinal
Instrumented.
fusion and laminectomy with decompression.
Yeah.
How long can I expect to be out of work?
Well, if I'm doing your fusion, then it depends on the kind of work you do. But my patients typically do go back to work 2 to 4 weeks after surgery. But it's really going to depend on who's doing your surgery. Every single surgeon does it different, and the restrictions are going to be for different periods of time. Just to give you an idea, when I do a fusion on the back, my patients do go home the same day. It's outpatient. Chances are your surgeon's not doing that. Outpatient. So I think for you, you need to find out from your surgeon how long they anticipate you being out of work. But if you were my patient and I did your surgery, you would go home the very same day as the surgery, and you would go back to work whenever you're ready. But most people can go back as soon as, depending on how many levels are being fused, a week, 2 weeks. Some people want 3 weeks, 4 weeks. But, if you're doing construction and you're expected to have no restrictions, then you're looking at probably 6 weeks out of work. If you can go back to a light duty job, like sitting at a desk answering phones or whatever light duty job you're doing, then you can go back very quickly as soon as you're feeling up to it. Most patients that are chomping at the bit to go back to work, in my practice, go back to work in a week or two because they need to provide for their family, so they want to get back to work quick. I'm saying this because The question you're asking is a great question, and it highlights a very important point. How successful your surgery is, how fast your recovery is, all depend on the surgeon and how they do your surgery, and also your therapy, your physiotherapy afterwards, and also your patient. Are they compliant? Are they doing what they're supposed to do? Are they following instructions? If you are my patient and having a lumbar fusion, and you follow my instructions, like I said, it's outpatient. You go home 2 hours after your surgery. So when could you go back to work? It's up to you. But my patients, the ones that want to go back to work soon, they'll go home. They'll go back to work in a week. The ones that want to take some time off and recover some more at home will take 4 weeks. So everything in between. I'm a patient advocate. In other words, I'm here to care for the patient and make the patient happy. So as long as the patient's request's reasonable and I can accommodate them, I'm going to accommodate them. And one more question I'd have for the person that asked, why undergo a fusion when you can do laser surgery? We've been doing spinal fusions now for 5 years here at the Surgery Center, Deuk Spine Institute. I've done spinal fusions for 20 years. And our complication rate is extremely low with spinal fusions. It's less than 1%. At the Surgery Center, we've had 0 complications. Oh, look at that herniation coming. You see it? It's sitting right on the nerve, or just under the nerve, I should say. Oh yeah, come on. Get out of there. So this is scarred in pretty bad. That's why it's, see the golden color? That's bone. It's calcified. This is what you call a calcified herniation. So we're out in the foramen right now, out in the neuroforamen. And obviously our nerve is going to be out here, just underneath this herniation. And the reason the herniation is not coming out, because it's scarred down really bad. Remember, your herniation is going to create inflammation. And the inflammation creates scar tissue. And the scar tissue will like tether down the fragments of herniation. Literally holds them down so they can't get out. There we go. Come on now. Get out of there. Beautiful. Well, so our patient here traveled from Chicago to Florida to have her surgery. Oh no, Minnesota. I apologize. From Minnesota. And I'm going to tell you a funny story later on in recovery. It's not so funny actually, but it just shows what's happening in medicine, and it's just really a bit irritating, to be quite honest with you. But her primary care doctor didn't want her to come to Florida and have this procedure done. The primary care doctor wanted the neurosurgeon up in Minnesota to do a fusion. And she told her primary care doctor no. So we're seeing more and more where patients are taking their health care in their own hands and taking control of it, which in my opinion is the best situation. Why? because I think patients are the most concerned. They're going to be the most concerned person about their health. And for too long, doctors, like primary care doctors, have abused their relationship with patients and overprescribed narcotics instead of sending the patients to get fixed. And that's really upsetting to me. People wonder, well, why would a primary care doctor do that? The answer is a neck pain patient and a back pain patient are the easiest patients to take care of in a primary care practice. Think about it. Most patients that come to a primary care doctor have high blood pressure or diabetes, and they're really sick, and they take a lot of time and effort, and they're very risky to take care of, and the doctor doesn't get paid more for taking care of those complicated patients. The easiest patient a doctor can have is one that comes in and says, I got back pain and neck pain. Will you just refill my Percocet prescription? And the doctor says, sure, here you go. And then they bill and they get money. All right, nothing wrong with doctors billing and making money, but that's how we got into this opioid crisis. If you look at who prescribed the most narcotics over the last 20 years, who is it, Dr. Patel? It's primary care docs. That's right. And to be honest with you, I don't think they did it like to hurt the patients. I think they did it, I don't know. I can't make excuses why they did it. All I can tell you is that's what was done. And that's why we have so many people on narcotics for pain rather than getting fixed like this patient. So, knowledge is power. And the fact of the matter is that neurosurgeons are not equal to each other with their ability. Some have greater ability than others. I'll be the first person to tell you that I am not going to do an aneurysm surgery on a brain because I'm not the best aneurysm surgeon. And so I would want my patients to get the best. I actually refer my neurosurgery patients out to other surgeons that do things better than me because I don't do them on a regular basis, all right? One example of that would be aneurysm surgery. Am I allowed to do aneurysm surgery? Of course. I'm a neurosurgeon. I was trained to do it. Was I trained to do aneurysm surgery? Absolutely. I was trained by some of the best in the world. Because I went to University of Florida in Gainesville, and we had Arthur Day. We had Stephen Lewis from Australia. Robert Miracle, one of the most famous vascular surgeons there is. And point is, I was trained to do that type of surgery, but I don't. Why? Because I truly believe that there are other places where my patients could go and get a better surgery than I can give them. So doctors should recognize that same fact with their patients and be honest with their patients and tell them, listen, the best way to fix your problem is endoscopic spine surgery like Dr. Deuk does down in Florida. If you had a brain tumor, I'll fix it. But if you have a herniated disc, the only thing I could offer you is a fusion. And honestly, I don't think a fusion is the best surgery for you. So I think doctors need to be more honest with their patients about what the patient's options are, but also about whether or not that doctor can provide that service to the patient or whether the patient should seek care elsewhere. And the doctor really should facilitate it. So in this patient's case, once she told her primary care doctor, I want to go to Florida and get the Deuk laser disc repair, the primary care doctor refused to give her her records, which was amazing to me because this woman is not crazy. She's completely sane and educated and knowledgeable. And the reason why she even found out about us is because her best friend is a nurse who had the same surgery done 2 weeks ago from Chicago. and has been telling everybody how great it is, that she's so thankful she didn't have a fusion, because that's all she was offered in Chicago was a fusion. And that's because that's all the surgeons know how to do there, is artificial disc and fusion. Nobody else knows how to do anterior cervical endoscopic surgery. So it's not surprising to me that that's all she was offered. But, you know, I've tried educating the doctors about the procedure, as I've said earlier. I've submitted papers for presentation at big meetings. My papers have all been accepted. I've given talks on this endoscopic surgery. I've shown the surgeons the videos how to do it, but they all want to bury their head in the sand. They don't care. They just want to keep doing fusions. You know, so I'll be honest with you, there's big companies in the United States that promote fusions, okay? And that's a big part of the problem. And these companies are companies like Medtronic, Deuk, and they make, quite honestly, billions of dollars a year on spinal fusions. And so they have a lot of doctors that they pay money to. You know, basically, in my opinion, bribes to keep doing fusions. They had one guy in the news about a year ago. He got $21 million, surgeon, for promoting fusion products for Medtronic. So this stuff happens all the time. I don't take any money from any of these companies. I don't think it's right to do. It's basically illegal, and they all try to cover it up as, you know, whatever, consulting agreements or all kinds of stuff. So I think doctors should stay true to their patients and do what's in the best interest of the patient, because there's really nobody else that's doing what's in the best interest of the patient except for doctors. Insurance companies don't. Hospitals don't necessarily. They're all trying to save money. Hospitals these days are trying to just stay alive, so they're busy trying to change their policies and making the insurance companies happy. So they're always cutting corners and trying to cut costs. Well, cutting costs is fine as long as you're not compromising the quality of care for the patient. You can actually see a vein down there. You see that on the dura right there, the purple? So I think if anything, there's a little bit more herniation here I could take out. But we're just about done with this section. How's my irrigation? Because I'm starting to see some. I'm sorry? Oh, good.
We have a question.
Anyway, I don't want you to all think I'm here to bash doctors. I'm just trying to be truthful with the public and let them know what's really going on. Yeah.
We have a viewer asking, what's the risk of infection with the spinal fusion versus the laser?
So great question from one of our viewers. What's the risk of infection with this procedure, Deuk laser disc repair, versus spinal fusion? Well, I mean, it's definitely going to be higher for a fusion. Why? Because a fusion is an open surgery. It takes longer to do a fusion than it does the laser surgery. The incision is much bigger, and we're putting in spinal implants with a fusion. Let's just wait a minute. Let me have a dilator. We're just going to wait a minute and try to get some of the bleeding to stop. It's really not bad bleeding. It's just oozing a little bit, but it's kind of obscuring our view. So why is a spinal fusion a higher risk for infection? Number one, bigger incision. Number two, longer surgery. Number three, greater blood loss. Number four, you're putting implants in the human body. Anytime you put a piece of metal or plastic in the human body, it increases the risk of infection. Number five, the implants themselves all have to be sterilely processed. So there's always a chance the sterilizer won't work properly and clean them and sterilize them and kill all the bacteria on them. There's always a chance of human error when processing the implants and instruments. And so basically the risk is much higher for fusion. That being said, at Deuk Spine Institute, in the last 8 years, we've had 0 infections. 8 years, 0 infections. And that has everything to do with what I do for the patients. I'm Dr. Ara Deuk-Majum, by the way, what I do for the patients before, during, and after surgery. There are certain things that I do, about 100 different things, that probably about 20 of them are different than every other spine surgeon, because they don't do these things that I do, because they cost more money, they take more time, and many times they don't even know that that's an option to do for the patient. But these strategies that I've developed over the years have reduced the risk of infection. Infections are horrible complications. I have not had a single spinal infection in 8 years. So that's huge. That's like hundreds of cases of spinal fusion. Cervical, anterior, cervical, posterior, lumbar, posterior. No infections. But to answer your question specifically, we've had 0 infections with the Deuk laser disc repair, what you're watching now. Endoscopic surgery, 0. I've been doing this surgery now for 13 years, almost 900 cases. Cervical and lumbar, we've had not a single infection. So you can't beat that. 0 is infections is as good as it gets. Right, Dr. Patel?
Yep.
I don't think you've had really any infections either, right? I mean, you've done how many thousands of pain management procedures? 37,000 procedures with not a single infection, Dr. Patel here at Deuk Spine Institute. So we're a very clean facility. There's other factors, all right? Like let's say you go to the hospital for a fusion, okay? What you're looking at is, number one, the person in the same room as you may have an infection. They may be in the hospital for an infection. Happens all the time. Hospitals usually do not separate patients with infections from those without infections. So I can't tell you how many times when I used to do these fusions at the hospital, I would go see my patient in the room, and the guy or girl next bed next to them, because they put 2 patients in the room, would be somebody with a hip infection or a knee infection, because it's the orthopedic floor. And the nurse, of course, go back and forth. Nowadays, you get 1 nurse taking care of 6 patients. So imagine that nurse, as good as he or she is trying to not spread infection, they're going to be rushed to take care of patients. I mean, 1 nurse should never take care of 6 patients, but that's what's happening in the hospitals. So the nurse is going room to room quickly without really, sanitizing themselves. Even if they just touch the chart itself could have bacteria. So what you're seeing is higher infection rates at the hospital. We call those nosocomial infections because they acquired in the hospital. At the surgery center here, we've not had any infected patients, so there's no bacteria here that would cause an infection, a bad infection like that. Okay? That's a simplistic way of thinking about it, but it's kind of true. Also, we don't do any GI procedures here, gastrointestinal procedures like colonoscopies. Colonoscopies being done at the same facility as orthopedic surgery has been shown to increase the risk of infections in patients having orthopedic procedures. So by not doing colonoscopies here or GI procedures, we're reducing the risk of infection for our patients. So that's another reason why we haven't had an infection. So there's a lot of reasons, but if I were you and you were thinking about having a spinal fusion, I would not do it at the hospital. I would do it at a surgery center where they specialize in spine care, like Deuk Spine Institute. All right, we're going to go back in and take a look. I've given the little bit of bleeding we were getting a chance to coagulate and stop. Hopefully it's behaving better now. It looks like it is. There's a little blood clot right there. So we're just about done. I think we need about, 5 more minutes? As soon as I hit this thing, it should blast the blood clots out of there.
We have a question.
Yep.
We have here asking, what is the waiting time for the laser surgery?
What is the waiting time for the laser surgery? If you came this week, we could do your surgery next week. We are able to fit people in and get it done quickly. What we need is a medical clearance. A medical clearance basically means that either your doctor or our doctor here has checked your EKG, your chest x-ray, your blood work, and that you're ready to go to surgery. So I've never in my entire career had a patient die on me in surgery or after surgery. And part of the reason for that is that we're able to check the patient out very thoroughly ahead of time and make sure that the patient doesn't have a heart disease that's going to kill him from surgery. So, or pulmonary disease or anything like that. All right, just about finished. So it looks like this herniation went through the posterior ligament and it was compressing the spinal cord pretty bad. I've got most of it out, probably about 90% of it. And I'm just going to check this foramen out again because she was complaining of right arm pain this morning before surgery. I want to make sure we address it. This is a herniation that's probably contributing significantly to her right arm symptoms. All right, it's looking really good. Let's go check the other side one more time. Make sure we're not missing anything. I like what I'm seeing. All the herniation that was there is pretty much gone. All right, that's about the middle there. And you never want to gild the lily. More bone spur. A little bit of disc. And yeah, the herniation I can tell has been here for a while because it's extremely scarred down. This is not like a recent soft herniation. This is like at least several years old herniation.
We have a question.
Yep.
We have a viewer asking, how would someone living in another state get cleared with their insurance company for procedures here?
How would someone in another state get cleared with their insurance company for procedures here? So great question. What you would do for medical clearance is you'd go to your primary care doctor and just tell them you're having surgery. And please do all the appropriate tests. That's really what it comes down to. And your primary care doctor should do that. So if you can't do that at home, then we could do it for you here. We have, at Deuk Spine Institute, we have EKG, chest x-ray, MRI. We have access to a CAT scan if we need it. We have cardiologists. We have anesthesiologists in our network. We have pretty much everything you're going to need here So if you're somebody who does not have time or ability to get a medical clearance done at home, don't worry. We can do it here. But for those people who want to go to their primary care doc and get it done before coming here, you just go to your primary care doc and tell them, I'm having surgery in Florida. I need an EKG, a chest x-ray, and my blood work done. All needs to be within 3 months of my surgery date. And they should be able to do that for you. They should be willing and able to do that for you. So, all right, just about done here. A little bit of blue right here. I'm going to take a look and see. I feel really good. I think our patient's going to do well. And we're just about done. And I'll tell you something. She's she's going to be doing well when we see her in recovery. But think about it. She had all this done without actually opening her neck up, without actually having metal put in, without going through all that risk of open surgery and, you know, implants and all that jazz. In case you're wondering, well, Dr. Deuk, maybe you do this because you don't know how to do a spinal fusion. I've done 1,000 cervical spinal fusions just through the front in my career. That's anterior cervical discectomy and fusion. As a matter of fact, the truth is I stopped counting after 1,000. And that was a couple of years ago. So, yeah, I definitely know how to do ACDFs. I still do them for some patients who need them. I wasn't sure this patient, for example, would be able to get this surgery done because of her, you know, of her anatomy. But we were able to do it, and I'm real happy about it. But she did all this without open surgery. She's going to go home in about an hour and a half, fully recovered. She'll have a little soreness in her neck from where we operated. But aside from that, she'll be back on her feet and back to really a normal life tomorrow. And there's no other surgery in the world that does that for cervical disc disease. So okay, we got the laser. Let's pull it back. Okay, got that, Luis? We're done. Now, Zach, would you mind showing our audience? Dr. Pill, will you pull that off? That's the fluid adapter. Would you mind showing our audience, Zach, her incision? Tell me when you're looking.
They can see it.
Everyone see that? Incredible, huh? The whole surgery, I fixed 2 herniated discs in her neck with a 4mm incision. Can you apply pressure here? Just for 3 minutes. We'll start breaking everything down. We're done. I'm going to come to the conference room and talk to you all, answer questions. So if you've got questions, type them in now, and I'll answer them for you. Other than that, our next surgery is a Deuk laser disc repair for the lower back. For those of you with back pain and herniated disc, we can fix your back pain and your leg pain. Our average pain relief is 95%. That means if you think about your pain that you have every day right now, take 95% of it away in your lower back and your leg. And that's our average. Average means if when we take all of our patients we do it for, and we ask them how much relief they get, we add up all their numbers and divide by the number of patients, the average is 95%. And that's documented, peer-reviewed, and published. All right, so we did a Deuk laser disc repair, right approach, correct? C4-5, 5-6, and we did RFA, correct? And it was on the left side? And Dr. Patel, what levels? Yeah. Perfect. I love it when a plan comes together. No complications. I'm going to call our EBL 5 mil. Dr. Santiago, thank you so much. Appreciate it. Everyone, great work. Nice job. This is a tough case. We got through it. And I think she's going to do fantastic. So for those of you watching still, you get to, hopefully you'll be able to see her being discharged in an hour and a half. And just look for the live stream. And I'm going to ask her how she's doing, how much pain she's having that she had before surgery. So we'll check it out and see what's going on. Why is there lead here? Luis?
Okay, everyone, Dr. Arojigmajan here with you. I'm sitting next to Zach. Zach's my wingman, and we've just finished up a 2-level cervical Deuk laser disc repair, endoscopic, annular debridement, discectomy, foraminotomy, osteophytectomy,